So a warm welcome at the School of Radiology. Pascal and myself, Matthias, we are really happy to have you here. Our dear friend Mark Lopes. Mark, who is one of the opinion leaders, experts, clinical experts, hands-on practitioners, everything together, researchers on contrast-enhanced mammography, has been here 2 years ago. And we are happy to have him back for a sequel. It's time to go a little bit more into detail about the idea behind these SEM symposia. Our mission in these SEM symposia is driven really by our experience, both as editors of two major journals, but also as clinicians and academics, that we really need more hands-on real-life teaching on SEM. Because there's a lots of mythology going around, lots of political debates, which kind of are more pushing in the wrong direction. We need free and easy access to cutting-edge SEM knowledge. This should be compact and case-based. And this session tonight gonna be developed on a case-based hands-on formats. And this can only be done by leading pioneers, and Mark obviously is one of the premier voices in that field. So far, we had 4 editions with more than 2,000 registrations from more than 50 countries. So we kind of hit the clock in this regard. The first was done by Maxime Jockelson in March 23. Many of you have been there. Then Mark joined us for the first time in October 23. And last year, Jonathan James did a fantastic SEM symposium also with a focus on the one-stop breast clinic, which was fantastic. And Maxime joined us again. And tonight, once again, it's my great pleasure, Mark, to welcome you on the stage. We're going to start your keynote lectures in a couple of minutes. And the keynote lecture will be a mixture of case-based review and of really cutting-edge knowledge. We will collect during the session all your questions. Please submit them directly to me, as many of you are already doing. And at 8:45 Berlin time, Central European time, the session gonna be ended. Maybe we have a little bit overtime, but you will get your certificate if you join the whole session. Pascal, now it's my pleasure also to introduce you as my co-host and dear friend. And maybe you share some words about our guest. I already spoiled a little bit, but you obviously have more to share, because the biography and the background of Mark is really impressive. Pascal.
Yeah, absolutely. So first of all, Mark, I think we talked in private about that once before. I actually applied years ago for the position that then Mark Lopes took in Maastricht. And I really have to say without envy that I would never have done what he has done there in Maastricht. And now when he left, he is really one of the absolute guys in contrast-enhanced mammography. I mean, in general, in breast imaging. He was also part and reader of the DENSE trial. So actually, the list of things that Mark achieved is quite impressive. But I think always we don't need many words. I think Mark can speak for himself. So actually, I would like to remove myself from the stage, and Mark, the stage is all yours. I'm personally very much looking forward to your presentation and to discuss it later.
Okay, well, thank you for your kind introduction, as always, Matthias and Pascal. I'm very glad to be participating again in your School of Radiology, which I think is a very, it's a very good thing that you designed over the years. I know you as perfectionist, so you see that it's the continuous development in the quality of the sessions, the quality of the presentations. And I also like that it's a diverse, there are diverse topics on prostate MRI, breast MRI, contrast-enhanced mammography, you name it. As we did in the lobby before this session started, I think personally it's very nice to just sit down, have 1 hour or 2 hours of really dedicated education, because in many times, as you know as well as me, that in conventions, you also do some social networking, you meet friends and colleagues, you attend some classes and presentations, but at the end, after a few days, you become tired and you become sort of saturated with all the information, and your attention level drops. And I think this is a quite nice alternative to have really focused educational meetings, which takes up only a little bit of time. You get your CME credits and you learn a lot from it. So with that being said, I'm very glad to be here. I'm going to present some cases. That was my topic for today. to share with you some interesting cases. And in between, I've collected some questions. It's not the purpose of actually having the correct answers to all the questions, but it's more to feed the discussion a little bit and to have the general idea of how everybody is thinking about and perhaps some mythology about contrast-enhanced mammography or how they deal with certain cases. So there's not always a right or a wrong answer to these questions, but it gives a little bit of an impression of how the group is thinking. So I'm going to go through a set of cases. There are various levels of difficulty. No really difficult cases in terms of things that you could never have guessed, just to have me have a feel-good experience. Some basic cases with a varying level of difficulty and with the various levels of pathology. So the first case that I wanted to share with you is a sort of a startup case, and it was a 41-year-old woman presenting with a palpable mass. No real complaints before, no family history, so rather a straightforward case. And for each case, I will show you the low energy images first, and I'll have you take a look a couple of seconds. Again, these are not really difficult cases in terms of that you really need to hunt for subtle things. So they should be apparent with a few exceptions on the slides. Just have a look yourself. I will not actually already give away which side she was feeling, because otherwise it would become too easy and not that challenging at all. And here you have the contrast-enhanced mammography images, the recombined images as they are being called. That's actually the proper term. Sometimes people call them the subtracted images. Well, yes, in its basis, it's a subtracted algorithm, but it's more than that. It's actually more of a combination of the two images, where subtraction is a large part, but it's not only subtraction. So that's why they prefer the recombined images as the proper terminology, as already defined by the ACR supplemental lexicon. So in this case, I think you see actually quite easily the abnormality, which was already there. And this was the ultrasound image that we had from the same lesion in the right breast. So my first question, just as a sort of warming up, would be what kind of Birat's classification would you assume this would be? And Pascal, for Matthias, do you have the polls for this, or?
Yes, unfortunately, I still have running the attendance poll, so let's do this more like a mental sort of thing. Let's use the first minutes for the.
No problem, no problem. So I think going back to the images on how to report these kinds of images, I think it's important to know that you have two basic steps in looking at a contrast-enhanced mammography. You have your normal mammographic image, like the ones you're seeing now, and then you have the recombined image. And it's always a very good thing that you use the descriptors that you use for mammography for the assessment of your normal mammogram, your low energy images. And then you have sort of the MRI lexicon to describe your recombined images. And there are some few exceptions with very specific signs that occur only in contrast-enhanced mammography. But in a very basic explanation, this is sort of what you do. And the other important thing to remember to report in your everyday clinical examinations is whether you see the lesions on only the low energy images, or do you see them only on the recombined images, or are they correlated? So do you see a mass that's also enhancing? And then you have to sort of make a combined approach. So in this case, I think everybody is expecting that this is a case that is highly suggestive of a cancer. I even would describe this as being coarse rim enhancement, which is suggestive of central necrosis, similar to what we're used to at looking at with breast MRI. And you also see this background of symmetrical nodular background parenchymal enhancement, which we're also used to looking at MRI. So it's roughly the same phenomena that you see on a recombined images that we're used to looking at on breast MRI images. So in this case, I would actually call it the BI-RADS 5. And the sort of the trick question in here was whether people would actually call it the BI-RADS 4A, or 4B, or 4C. which is absolutely fine if you look at the conventional mammography images. But you should remember that at the current edition of the BI-RADS lexicon or the supplemental images, it's not recommended to use the 4A, B, C classification for contrast-enhanced mammography. That's sometimes a mistake that I quite often see from fellow colleagues. You can be for, it can be against, and maybe it will change in a future edition, but currently this is reserved for normal mammography, tomosynthesis, and ultrasound, and not for contrast-enhanced mammography or breast MRI. So in general, this was, as I would call it, a subtle asymmetry in the upper outer quadrant of the right breast. It was very difficult to delineate on the low energy images, and you see it much better on the recombined images. And there you can actually assess the size much better. There it also was an irregular mass with rim enhancement, coarse rim enhancement. We did the ultrasound, and in the end, it was an invasive breast cancer of no special type, high grade, and with HER2 negativity and also hormone receptor negativity, which is already a little bit suggested by the rapid turnover rate with the central necrosis. This suggests something really aggressive. We know this phenomenon from breast MRI, and you can still observe the same things that we've been used to be looking at on breast MRI, also on contrast-enhanced mammography. So for the next case, I selected a 60-year-old woman, and she had a palpable mass. This time I'm going to disclose the site. It was in the left breast, and it was tender to the touch. It was a rather painful lump in the left breast. So this is, again, the low energy image. As you can see here, I will always give you a few minutes to process the images before I continue to the craniocaudal views of the breast. And actually, what you can see here already is an asymmetry in the amount of glandular tissue in the upper outer quadrant of the left breast. Of course, that's very obvious. But now I'm going to give you the information on the contrast images, the recombined images. This is one view, and this is the other view. So here again, what BI-RADS classifications would you give to this abnormality? And if I don't get a sign or a clue or anything, I'm just going to continue. I think here the proper BI-RADS call that you would make is actually BI-RADS 2. Because you see the asymmetry, which was actually present, and it was palpable to the touch. It was tender, which can be a very good reason to be just normal glandular tissue. Yes, it's asymmetrical, but not every asymmetry is a proven breast cancer. You can have some asymmetry in the glandularity of your breast. And you see absolutely no enhancement whatever. And yes, there are some lesions that show very subtle enhancement, like invasive lobulars or mucinous carcinomas. But if they would become this big, you would, one way or the other, would still have some kind of enhancement being present there. Seeing absolutely no enhancement in this big area, that already suggests that it's likely comparable to glandular tissue. So here I would call it the BI-RADS 2 as an end result, and a negative SEM case for breast cancer. My colleague from that time, when we were still a little bit getting used to contrast-enhanced mammography, did do a targeted ultrasound and also didn't detect any abnormalities. And we learned from having a physical contact with her during the ultrasound that she was examined in another center many years before. So out of curiosity, we retrieved those images. And these were actually the images that were made in 2013, I think maybe 4 or 5 years before. And here you can actually already see that the asymmetry is already present. The glandularity has dropped a little bit over the years, which is quite explainable, but you already see a little bit more compact glandular tissue in the upper outer quadrant of the left breast. So that's already suggested to us that it was already present in early years, and for some reason it gave complaints, but absolutely no worries about having a breast cancer. So here you can see that contrast-enhanced mammography is also a very good problem solver, has a very high negative predictive value at par with breast MRI. And as I always been taught by my mentor, Professor Buttes, he said, well, if you have a negative MRI in these cases, you can actually say that there's no cancer present at this point. There's no other reason why to continue follow-up in these cases. Now, continuing with the next case, it's a 72-year-old woman, and she had a nipple retraction noticed while doing self-examination, and also a palpable mass in the retroareal region of the breast. Now, this is what her low energy images look like. And again, you already remember that I told you as the clinical information that she had a new developing nipple retraction. This is the second view. Not that difficult, I think, again. And here's the recombined view that you see. So actually, even in very challenging areas like the area behind the nipple, you can still see when you have a very good profile picture of the nipple and the nipple complex, you can actually see the architectural distortions and the mass forming behind the nipple. It's a little bit challenging to really assess nipple invasion. Sometimes it's really a dedicated request from a surgeon to ask whether he can perform nipple sparing mastectomy or breast conserving therapy. In those cases, I would always use MRI. The reason behind it is that sometimes you get an intramammary overlay of the nipple within the breast, especially in these cases where you have some traction on the breast and it sort of projects within the breast, and you don't really get a very good feel on what's the true tumor extent. As you can remember, in the breast MRI, in the standard coils, the breast hang freely in the coils. So you can actually, without even touching or manipulating the breast, you can see the spontaneous localization of the tumor, also with contrast, and you can much better appreciate the involvement of the nipple complex, sometimes even with dedicated sequences that you have. So in this case, you might want to consider an additional MRI, but then it would be for a very specific question, namely, can I do a nipple-sparing mastectomy or a nipple-sparing breast conservative therapy in these women? So those are, again, very dedicated questions where you need MRI instead of contrast-enhanced mammography. And that's also what I always try to advocate. It's not a discussion of one or the other, or you should do one and the other one is forbidden. No, not at all. You can think out loud and use both modalities where you think the strengths and weaknesses lie to sort of take the best care of your patients. This is the other view, and this is where you already see that with the fold behind the nipple, it's much more difficult to assess really the true relation of the tumor within the nipple complex. But that's not only the only case that I wanted to show you this case, because there's also an artifact being present in this case. Now, the question is, what artifact did we observe in half of the images that I already showed you before? I'm going to go back. And this was the poll.
And if you want, we can all now go to the questions as we already closed. So if you are fine with it.
Yeah, see how this goes. Otherwise, if it still crashes or anything for any reason, I think we're just going to skip the question. So
absolutely. This is in German. Sorry for the fast one, but A, B, C, D, E is international. And for those who are new in the field, Mark, maybe you can spend a minute or two in explaining what these artifacts are all about.
Well, the different artifacts that you can encounter on contrast-enhanced mammography are the ripple artifact. Those are small black lines suggesting some motion mismatch between the two exposures that you have. You have a low energy exposure and a high energy exposure when you look at the techniques behind contrast-enhanced mammography. A breast-in-breast artifact, which is apparently the choice of most people here, is the most common artifact that you have on contrast-enhanced mammography. But there is a big but. You hardly see them anymore with the newer generation of systems. So the latest systems like Pristina, Hologic, Dimensions, and everything, you almost don't see any breast-in-breast artifacts anymore. This was a small, darker band at the periphery of the breast, and you quite often saw them when old mammography systems were being redesigned to do contrast-enhanced mammography. Right now, everything is incorporated. So practically the chances are very high that you already, if you buy a new system, you already have the capability of doing tomo, contrast, and everything, but it's just licenses that you buy and switch on and off, because it's much easier for vendors to produce the machines like that. So it's much more dedicated and much more streamlined when you look at that from that perspective. An eclipse artifact is nonsense. That's not a true artifact for contrast enhanced mammography. A calibration artifact can be seen when you had surface and you see the phantom still projection within the images. So then they didn't do the calibration again prior for the release of the system on both spectra. And what I was actually talking about is contrast splatter. Now I'm going to try to go back, and yes, here it is. Let's see. What you see here in the central part, that just prior to just in the posterior part of the breast, just ahead of the pectoral muscle, you see these two white dots. And you can actually see them also on the contrast, on the CC views as well. And you see them both breast on the same location. And they mimic a little bit like microcalcifications or a very small calcification, but you should remember that the recombined image is in its basis a subtracted image. So calcifications should always turn black. If you have calcifications and they turn bright white like this, and you have them in both views or at the mirror view or anything, you should be very cautious that you're not looking at contrast splatter. And it seems, well, why is contrast flying around? No, but you would be surprised how many micro bubbles or micro splatters are being present on detectors. It's not very common that you see it, but it's also not very rare. I think we see it 2 or 3 times on a yearly basis. And I've also talked to other centers which also encountered. And if you know where to look, it's very easy to detect it. But again, it's rare, but not that rare that you never will see it in your career. You will encounter it if you do a certain number of contrast enhanced mammographies. You will encounter it at some point. So please take notice of it. But this is a contrast splatter artifact. So the correct answer was D. Okay, so for the next case, number 4, we had a 51-year-old female. She was recalled from breast cancer screening, and as you know, as one of the authors of the RACER trial, which focused on recalls from screening, and we did that over many years. We have the most cases and most experience with these recalls. And this was actually the low energy image. So in general, it would be the same like the screening mammogram she had maybe 1 week before. So you can also assume that this would be the screening mammogram.
Should we do a quick pirates?
Yes.
Based only on this?
This is very difficult, so but go ahead.
Well, these are experts here.
Yeah, sure.
There are no wrong answers. The only wrong answer you can give is the answer which you do not give. Don't be afraid of wrong answers. Just engage. And for those of you who had troubles or missed the attendance poll, we will reopen it at the end of the session again, so don't worry. And you may also write us into our office a quick email to state your attendance to get your certificate. So don't worry.
So shall we just agree that if we are over 50, that we are going to?
Well, let's wait for 100 because your audience is huge.
Okay, let's go for it.
But you are the boss here. I'm just your humble assistant.
Just being wary of the time, so cautious of the time. So
yeah,
we'll see how it goes.
105 answers, so people are happy, and it seems to be difficult. So
actually, if I would recall this in the Netherlands as the screening radiologist of our country, I would actually recall it for a BIRADS 4. But I still think it would be very difficult to really appreciate it because if you look at the right mediolateral view and you see the posterior nipple line and you see the edge of the pectoral muscle and you go down, especially at the edge of the image, you see some small calcifications over there. If you look very carefully, in detail, you see them even more, but there was a small cluster of some pleomorphic calcifications there. And that was the reason why this lady was recalled. Now, being one of the primary investigators of the recall of the RACER trial, we do contrast enhanced mammography in all these cases. And now it's stuck again for some reason. Let's see how this works. There it goes. I seem to have solved the problem. You cannot appreciate it on the CC view. But then in every case, we do contrast-enhanced mammography in these women, regardless of their reason for being recalled, because we learned from the RACER trial that we detect approximately 5% of cancers like this. So you're recalled for some other reason, and we detect by using contrast-enhanced mammography another location of a breast cancer. And retrospectively, we had about 4% of these findings. And prospectively in the RACER trial, we found 5% of the cases that were being recalled. We detect something else, some other cancer at another site, which was not being recalled or anything. So that sort of reinforced us to keep doing contrast-enhanced mammography in these recalls. For some reason, you're overlooking something, or that something pops up on the other side. This is what it looks on the CC view. So it's actually a true lesion. It can be observed in 2 views. And we did a stereotactic biopsy with a vacuum system of the calcification. Those were actually benign calcifications. So you can imagine if we didn't do contrast-enhanced mammography, we would have neglected the cancer, and she would have been recalled 2 years afterwards, probably for an involving mass somewhere else in the breast. Right now, we didn't have the opportunity to do contrast-enhanced stereotactic biopsy at this time when she presented herself. So we did a workaround with a breast MRI. We saw the lesion as well, and we did an MR-guided biopsy through the Maastricht University Medical Center, and it turned out to be an invasive breast cancer. So with that, I can also show you the MRI results. And actually, you can see in the center part of the breast, a similar phenomenon, similar size, similar morphology, an irregular mass. It looks in all aspects a little bit the same as the lesion that you were looking at on your contrast-enhanced mammography. We also looked at the small hematoma that we had on after the biopsy, of course, and there was no additional finding there as well. So a benign recall, a false positive recall, but in the end, it was a true positive case because we detected something somewhere else. Now, this is just a matter of opinion. And I'm very curious to learn the opinion of the crowd, that this is always the biggest question that I have. Well, what's the better modality, contrast-enhanced mammography or breast MRI? Or do you think it doesn't really matter? There's room for both.
What's up? Diplomats all around.
We're all friends. We're all winners.
Yeah. I mean, this is actually one of the missions of the symposium, because Pascal and myself, we have been sitting after so many sessions where we really experience some sort of fight. You know, I'm coming from breast MR, and you are more from SEM side. There's no reason to be fights. We're rowing in the same boat. So I like the crowd. I will now close it, and so 2 out of 3 said, okay, we both are equally.
Well, I actually,
but some are more equal.
Yeah. I know where that's come from, but I think I agree with the general opinion of the crowd, because there's no one or the other. Both modalities have their strengths and weaknesses. We know in general that the sensitivity of a breast MRI is a little bit better, but you're talking about a handful of percentages. But the specificity is a little bit in favor of contrast-enhanced mammography. So it's a little bit, we're detecting a little bit more with breast MRI, but it comes at the expense of more false positives. And as I was being trained by my statistician, if you do, every diagnostic test is a balance between sensitivity and specificity. You should not always aim for the highest sensitivity if your specificity is poor. The reason how I explain it to residents is by saying, how can I get, if I have a batch of recalls from 1 day production, so say 100 recalls, and I always make a bet with them, and I say, I can find every cancer in that batch without even looking at the images. How do I do that? And some of them know, some of them don't. So we're aiming for a 100% sensitivity. And then my answer is, recall everybody. Then I'm going to find the cancer, but I'm going to make a lot of people anxious and nervous with a lot of false positives. So my specificity is very poor. And that's what I tried always to exaggerate a little bit, that it's important to have the balance between the two, not the one or the other. Now, let's see. Case number 5, 49-year-old female recalled, again, first round of breast cancer screening. Yes, in the Netherlands, we do it from the age of 50, if you are a very careful observer, but it's you're being selected by postcode in the year that you become 50. So sometimes there's a 49-year-old woman in the cancer screening as well. So here again, this is virtually the screening mammogram and also the CC view. Please assess for
Let's
it.
do a quick global bi-rates, huh?
Yeah, just throw it in there.
It's out. I liked it. Imagining a big crowd.
Yeah, and in the Netherlands, actually, we can only recall by 0, 4, or 5. That's a little bit different. That sounds a little bit strange, but that has all to do with the way we recall them through different pathways. If you have a very low suspicion, like bi-rate 0, we follow the route through the family doctor, the general physician, directly to an imaging department. And the other way, the 4 and the 5 are calcifications and speculated that we know that probably there's going to be a positive cancer case. So we recall them to the surgeon and a dedicated breast center already. So that more has to do with financial structures and care pathways than actually the true assessment. But here I can see the majority says bi-rates 4.
Yes, that's correct. And we do have a...
Well, here I actually don't agree because it's the mass that is being observed in the, here you can see in the lateral part of the right breast. It has a very low conspicuity. It's very low in density. It's largely well-defined. So in every aspect, yes, you have a mass here, very apparent in sort of no man's land, and it's a very easy mammogram to read. But it has the appearance, well, you have the impression that this is a cyst, and you don't have really the confirmation that this is a very irregular or speculated mass. You don't have any calcifications or other specific hallmarks that you doubt of this being anything more than a cyst. However, you would need additional imaging to solve this problem, and that's what they call the bi-rate 0 classification. Additional imaging is needed. So in this case, a recall in the Netherlands would be because of a bi-rate 0. Again, we do contrast-enhanced mammography in these cases. And this is the recombined image that you see.
You can reopen it, huh?
Yeah, sure. Maybe they want to adjust.
Absolutely. No bi-rate 0, no, please. Forbidden. No certificate.
Ah, look.
Just kidding.
Now, bi-rate 0 would be very challenging because then I'm going to ask, okay, what can we do next then? Because we're running
Head MR.
we're running out of imaging modalities then.
Absolutely.
You could do follow-up, but I'm personally not very much in favor of follow-up.
Okay, so we have 100 responses.
I can think we see where it's saturating.
Absolutely.
Let's say. So yes, indeed, this is a bi-rate 2 right now, because what you see is at the site of the mass, you don't see any enhancement on Hall. Not even no enhancement at all, but what some people call this even a negative enhancement. So the appearance of the mass is becoming black, more black than the surrounding glandular tissue. This suggests that this lesion doesn't have any vascularity, and this is the typical sign that you see on contrast-enhanced mammography of a cyst. It's highly reliable, and what is it being called?
Clear A.
I'm for the lob sign.
Yeah, but that's not the correct answer. I'll give you that.
Damn.
That's a good one.
No, I was raised very nice by my mother, so I don't have any attempt of calling signs myself. But the way these things go, this was actually thought of by me and Ulrich Lalji, who was at that point a PhD of mine, a fellow breast radiologist. And this is not something that when we started doing contrast-enhanced mammography, we saw this and we did an ultrasound. We saw this, we did an ultrasound. It's not something that I say, well, I had a glass of wine in the back of my garden. I said, this is indeed the correct answer is an eclipse sign. No, that's not how it went. We did over and over. We did targeted ultrasound, and each time it was a cyst. And in the end, we sort of started pioneering it and saying, well, if this looks like this, we're going to call it a sign for easy communication. And we say, we're not going to do an ultrasound anymore. This is typical CEM sign of a cyst. It's called the eclipse sign because we thought it would resemble a solar eclipse. So you have a very black spot and only a very thin line surrounding it. So no, we didn't call it the lobus sign. We didn't call it the Lalji sign, but we thought it was an eclipse sign. Sunset sign is, of course, a lot of BS. That's not something that's being used in contrast-enhanced mammography. And a keyhole sign, as probably many of you will know, is a sign that you can see when you're talking about an implant rupture on breast MRI. We started doing this many years ago, and with the RACER trial, we also applied it prospectively. And when you carefully look at our data on the RACER trial, you actually see that with a little bit of confidence, at first, it's a little bit of a leap of faith to leave out the ultrasound. I fully agree with that. But in the end, when you have you convince yourself that you can distinguish this sign, it's very reliable, and you don't need to do the extra ultrasound anymore. But again, that takes some getting used to. And just for teaching purposes, I asked these patients to do an ultrasound. Otherwise, I would not have done it, but this is actually the cyst that was at that sign. So number 6, 69-year-old female, prior history of breast cancer, was treated with conservative therapy. And she presented to us for follow-up after 8 months, so sooner than the annual checkup, because she felt something in the other breast. And this is the image that we have. Surgical changes on the left side. This is the other. I think this is too easy to really score about.
Yeah.
But it
Let's relax here.
It has an other educational purpose. Otherwise, this case would be too easy, of course. And this is what the recombined image looked like. Again, the second view, you see some skin retraction, maybe some skin thickening there as well. And I think to everybody, it's very apparent that there is an ill-defined irregular mass in the medial part of the right breast. It shows heterogeneous enhancement, so it looks very much like a straightforward case. And that was also the catch, because when this patient was returned to us on the multidisciplinary tumor board meeting, I will go back to the case for change. When she got back to the MDT, they did a breast conservative therapy again for the right side, and the surgical margins were involved for DCIS. And what I always do at that point is just by myself recheck if we overlooked anything now knowing the final results. And when you actually look at the area behind the nipple, you see some spiculated, some very small nodular non-mass enhancement growing towards the nipple. And if you actually look very carefully, I'm not sure whether it's... I have an outtake, some slides after this, but you can actually see calcifications appearing behind the nipple as well. So I discussed it with the radiology who did this case at first, and she actually admitted that she said, well, I'm so enthusiastic about contrast-enhanced mammography. I saw the mass, I saw enhancement, bada bing, bada boom, biopsy, done. And she said, I stopped thinking. So she didn't hunt for any additional abnormalities like subtle microcalcifications or maybe an intraductal component or anything. Because if you look carefully, you can already on the left side, it's the outtake of the current situation. And 1 year before, you already see some small calcifications occurring. And even 1 year before that, you see absolutely no calcification. So this is how it goes in clinical practice. You see small changes appearing, and sometimes you have this aha erlebnis afterwards, and you say, now I know, but in hindsight. But I thought it was very brave of her to just admit that she said, well, I'm so enthusiastic about contrast-enhanced mammography. I thought this is easy. She feels something. There's a cancer there. I know the size. It's done. And that's the difficulty also with contrast-enhanced mammography, that you tend to look at the recombined images too much. So remember, as I always try to teach the residents, contrast-enhanced mammography is an adjunct to mammography. It's not a replacement of your mammography. It gives you more information. It doesn't give you a replacement option for your mammogram. So always continue to use your head and to use your thought and search for everything and make use of the extra information that you get from the contrast that you applied. In the end, she had a mastectomy, and it was confirmed that there was a lot more extensive DCIS towards the nipple. So in the end, she got the proper treatment, of course, but it should have been done at a first attempt immediately. Now, I have prepared a statement regarding contrast-enhanced mammography and breast, well, microcalcification. So not the popcorn calcifications or all these easy things, but assume the difficult, very microscopic calcifications. What's your opinion? Number A is if you have calcifications and you don't see them enhanced, and you can just leave your biopsy. You can use it to assess the extent, so you can use it to assess the extent of DCIS. Calcifications can be better observed on your contrast-enhanced mammography examination, or the diagnostic value for contrast-enhanced mammography for calcifications is limited. And here I see that there's a little bit of a more variation in the things that people thought. Also, the numbers are shooting up a little less quickly than before. So people are probably reading the sentences very carefully and trying to figure out what I mean and where the catch might lie, but it's not a catch. It's just something that I frequently encounter during workshops and presentations on what to do with calcifications and contrast-enhanced mammography. And here you see quite a variation. So I think in the end, the correct answer is D. So the diagnostic value of contrast-enhanced mammography for calcification, for the assessment of calcification, is limited. So far, there is a handful of publications on this. One of them we did ourselves. And that was based on the fact that on one retrospective study, we once looked at the image quality, and we had the assumption that you might see the calcifications a little bit better on the low energy image of a contrast-enhanced mammography when you compared it to the very recent screening mammogram. This was a very small p-value, it's very 0.046, something like that, and we couldn't confirm that in later publications. So yes, it was assumed, we studied it, but it wasn't robust. When calcifications do not enhance, there's nothing to be said about the grade of the calcification, so be very careful about it. When you have BI-RADS 4 class classifications and you need to biopsy them, if they enhance, I tend to call them BI-RADS 5, because often you have a DCIS or an invasive carcinoma there, and you need to biopsy them. If they don't enhance, they still are suspicious based on the morphology, and you still need to biopsy. You're going to miss too much DCIS or cancers if you're going to use it to downgrade it. So that's what's my argument with the value is limited. So answer D, because we also did in our study to look at how well can we measure the extent. And yes, sometimes you have a little bit more enhancement than you see the calcification. Sometimes you have more calcifications than you see enhancement. But there's no really true continuous line to be discovered in those findings. So on an individual case, you might have some benefit on it, and I will show you a case later on. But in general, on a population level, it's not really a very powerful tool to use in the assessment of calcification. But there are other reasons that you could consider contrast-enhanced mammography in calcification, and I will show them to you in the next case as well. Now, the next one, number 7, 61-year-old female, lost her mother because of breast cancer. And the way these things go, she detected a new palpable mass in her breast, and she said that breast is always very lumpy to the breast. And these are, of course, the really pain in the necks mammography with these kinds of density levels. This is, well, I don't say extreme dense, this is extreme dense breast, so to speak. Almost impossible to see anything about it. When my fellow colleagues say, well, these are the most difficult breasts to screen, I never agree, because I said this is the most easiest one, because I cannot detect anything on those other than large tumors or calcification. So it's how you see it. So for me, these are the easiest to view, because I'm looking like it, and I said, well, nothing big, but subtle things I cannot be sure. But when you use the contrast information next, I will show you. But first of all, what would you do in these kinds of cases? So she has a palpable mass. It was in the left breast. I can share it with you. And you have these kinds of densities, because density is a very hot topic, especially in the Netherlands, with all the publications of the DENS 1 trial and now continuing on with the DENS 2 trial. And of course, you can also have a combination of modalities, but it's just roughly to have an idea of what people would do.
Yeah, select your favorite.
Yeah.
In this case, and it's all obviously depends from your practice and from the practice in your country.
Yeah, and I think if you do an ultrasound, you should do it bilateral, of course, especially in these levels of density. You could consider to do a breast tomosynthesis as well, or maybe a one-stop shop and use the synthetic mammography data in that aspect. That could also be a practice that you use. But we also know from studying these high levels of density, the effect of tomosynthesis also wears down. So it turns out that it works fine in category B and C, but in D, it's sort of the effect of tomosynthesis is being left out. And to be honest, in my opinion, in these kinds of women, and we should really get some more data on that to really put our foot down and say, well, in these kinds of extreme densities, we should really offer, and again, there's not one or the other, but I always say something with contrast. And whether you prefer breast MRI or contrast-enhanced mammography, that can be seen. But I think normal mammographic images are failing us in these levels of density. We did, of course, a contrast-enhanced mammography. Otherwise, we wouldn't be doing this workshop. Again, I need to help the computer a little bit. And this is the contrast-enhanced mammography recombined image that you see. So you see here a small area of irregular enhancement. Actually, what you saw on the previous images here, let's see if I can put them back. You can see already a small distortion in that area appearing, but that's in hindsight. You can also see it on the CC view if you look carefully there. And you see, well, maybe you should call this an irregular heterogeneous enhancing mass, or if you're more in the area of an architectural distortion, you would call it a regional non-mass enhancement. That's always a little bit of a gray area that we're also familiar with breast MRI, but it's a little bit the same terminology that you use in breast MRI as well. So here you can actually see that even in these dense breasts, particularly if you have limited BPE, background enhancement, you can actually very nicely delineate the tumor extent as well. And that helped us a lot. It turned out to be an invasive breast cancer of no special type. So in these high level of densities, even something with contrast would help you a lot. Now, the following case is 69-year-old female, no complaints, again, a recall from screening. So here we can do a BI-RADS poll again, if you would like, Matthias.
Absolutely.
I will show the images again. So this one and that one.
It's up again. And they are popping. I already collecting in the background questions for the Q&A, but as we already had a case on this matter, background enhancement is been discussed in the background in the chat a lot.
Yeah, background enhancement is of course very difficult. You see that there are some influence like age, hormonal status, everything that we already know from MRI as well, of course. And you see that you have a very good association between MRI and contrast-enhanced mammography, BPE. I know one study also from the group in New York by Maxine Jochelson and Soren, I believe, from the top of my head, that they show that, yes, you can have BPE, but in most of the cases, it's doable in terms of assessment of the images. So it's only maybe a handful of cases, maybe 10% or higher, that is really becoming that much that you have difficulty in assessing the images properly. We know that from MRI, and we sort of run into the same trouble with contrast-enhanced mammography. In some cases where I have dense breast and a lot of BPE on contrast-enhanced mammography, I do an extra MRI just to play around a little bit more with the signal intensity time curves, the DWI, so I have more information to abuse, so to say, to get the proper impression of what's actually going on and if I'm not overlooking anything. I think in very extreme BPE, the benefit of MRI is that you can make these color overlays with your signal intensity time curves. And then in general, everything turns up blue, and then just easily scroll through it. If there are areas outside of the tumor that I already know that suddenly pop up with red spots or green spots that are other than the majority of the glandular tissue. And that's not possible right now with contrast enhanced mammography. So if you have very challenging cases where BPE is an issue, you might consider doing an extra MRI as well. But you will see BPE there as well, but you just have more options to play around with and see how they line up. Maybe in the future with the rise of AI and anything that we can be helped in some extent by that. And we're also collaborating currently with a group in Amsterdam and New York as well to see if there's even diagnostic information there. We know from MRI that the amount of BPE can be a risk factor for breast cancer. And there's also some preliminary information that the same holds true for contrast enhanced mammography. So then you would have density, not only density as a risk factor, but also does the density enhance, yes or no, as a risk factor. So those are very exciting next levels of contrast enhanced mammography, even that we're still reaching out to as we speak. So here the proper recall was by BRAD4 indeed, but it was for the calcifications that are now visible in the lateral part of the right breast. That was the actual reason for the recall in this woman. So we did the contrast enhanced mammography, as you see. And what now? Ooh, did we not look at something? And again, it's not a matter of missing anything, but your contrast information is drawing your eye towards certain abnormalities and forcing you to reassess that area again. And so the calcifications in the end were benign, but this enhancing area in the left breast turned out to be an invasive cancer.
Can you show, this was, sorry, quick, can you show the MLO again? Not, and the, yeah, wow, okay, that's cool.
So, and this is actually, when you go back to the screening examination, this is how it looks. The one on the left was the recent recall. So that was part of the image examination that she was recalled for the other side. And 2 years before, you actually see a bare area just prior to the glandular tissue. And you see some gray appearing there, not masses, not anything, very subtle. But it turned out to be a very big invasive lobular carcinoma. And we know that these invasive lobulars can grow like this with these Indian files and these strand-like morphologies. So they can be tricky. They can show low conspicuity on contrast enhanced mammography. So they can be challenging on contrast enhanced mammography here as well. But again, this is a very impressive case because if we looked at this with only an ultrasound, we probably would have missed it. We biopsied the calcifications on the right side. They were benign, and she was discharged back to the screening. And then the invasive lobular carcinoma, which was already very big on the left side, was continuing to grow. We had no treatment at all, no chemo nor nothing. So these are just a handful of women which are really benefiting for the additional information of contrast enhanced mammography. And again, this happens in 5% of the cases that we see for this indication. So that really makes us want to continue on this strategy. And I would also like to invite you to read the RACER trial results to see how these would work out in your own practice. I can also share that right now a cost efficiency analysis is also being prepared to submit for publication. And it's also looking very good on the side of contrast enhanced mammography. And then you have something which is always cheaper, in many cases also better and more practical to use. So with level 1 evidence, I think the recalls from screening should be a no-brainer anymore as an indication for contrast enhanced mammography. Other indications are still a little bit in progress, I think. So number 9, I'm looking at the time also, so I'm going to speed up just a tiny bit because I also have a biopsy case at the end, which I think for the audience can also be very interesting. So number 9, first round screening recall, no prior history, and oh my, here we go again. But this
You're up. You got 20 seconds. 22.
Well, you don't in screening. You don't have more than 30 seconds. If you
Exactly.
if you would ever like to finish your day's work, to be honest.
Talking about finish your day's work, there's is supposed to be scheduled for another half an hour, and we have like 15 minutes for case read. If you need more, Mark.
No, but I think we can finish in the remaining 10. Maybe I'll skip one case. That's not really a big problem, but I really want to share.
No. You go ahead. You're the boss. At the School of Radiology, we are hanging and reading great cases as usual.
So
I'm sure.
I think the calcifications are a no-brainer on the right side. So it's a BI-RADS 4 at least. I think with this extent, with this morphology, you can also stick your neck out a little bit and call them 5, because this is if this is not DCIS, I wouldn't know what to do anymore. Very large extent. We also do contrast-enhanced mammography in these cases. And then you actually can see here, especially on the CFC view, you see a lot of BPE, but you actually see a sort of a curved appearance of segmental or linear non-mass enhancement covering, be very careful, the black calcifications on the recombined images. So this is what I told you before. The calcifications should appear black on the recombined images. Very coarse calcifications can be a little bit suboptimal or suppressed, but those are fibroadenomas, so those are not challenging calcification, but these kinds of subtle calcification, they should be black if they are true calcifications. And like I said, the diagnostic information is maybe not very powerful with calcification, but here I need to choose a target for my vacuum-assisted biopsy. Based on this information, I would biopsy the calcifications in the back part of the breast because they also show enhancement. So the chances of me finding some invasive component which has implications for maybe reconstructive surgery, sentinel lymph node procedures, you name it, the chances of anything finding invasive is highest there. Normally, I would just pick a site quite randomly, but now I would dedicate my target a little bit more, still with conventional stereotactic biopsy, but a little bit more towards the posterior part of the calcification. So yes, you see the calcification, they are already suspicious, we need to biopsy them. But here in these cases, sometimes contrast information can help you a little bit to sub-select the calcification that you're most interested in, especially if it's a large area. And if this is only DCIS in an MDT meeting, you could already say, well, okay, this is DCIS on biopsy, but you should tell the patient that there is a chance that it will be upgraded to an invasive cancer. That changes your dialogue in the surgeon's office a lot. That, okay, we have DCIS, we're going to work with that, but be wary that we might need to upgrade it so that people are not surprised. So even in those cases, you have information there as well. In the end, it was pure DCIS, so no worries there. Case number 10, 52-year-old female. Again, a recall from screening. Here we go again.
And to spoil the discussion and use the seconds we have while the polls are running, there are a couple of questions about DCS. What's your approach to DCS and SAM and vice versa? When do you do it?
Well, if we have a clinical case with microcalcification that is not being recalled, I would personally prefer to biopsy the calcifications and prove that it's a DCIS, and then work from there. I don't really do an additional MRI or contrast-enhanced mammography in general to assess the extent of the DCIS, because usually it's in line with the extent of the calcification. You have some subtle differences, but you should try to figure out, is this still breast conservative therapy or is this becoming a mastectomy? It's not really that important if your calcifications are maybe 5 centimeters and your enhancement is 6 centimeters, because you already need to do a mastectomy. So it's really trying to figure out what information would you still need, and do I use a contrast-enhanced mammography for that, or am I satisfied with the images that I have? If you have very challenging breast with a lot of glandular tissue and you're not sure, and you need some more reassurance that the rest of the glandular tissue that you're looking at is not abnormal, then you can sort of use the high negative predictive value of contrast-enhanced mammography to rule out that you're overlooking anything elsewhere in the breast. So you really need to figure out where the strength and weaknesses lies of these kinds of techniques, and then apply them as a dedicated radiologist, breast radiologist that you are, where it would be most useful. So in this case, when you look at the Birat's recalls, it's a 4. This was actually recalled for the mass, which was well defined in the lateral part of the left breast. You can see it here in the posterior part of the left breast. And it was recalled with a Birat 0 because it was very well defined, oval in shape, and again, very low density. So assuming that this was a cyst, but we don't know for sure. So in the Netherlands, this would be recalled for a Birat 0, again with a slightly adapted classification. Now, this is what we saw.
Oof.
So again, you see an eclipse sign at the mass, and going back, well, the mass is there. So maybe some of you picked it up, maybe some of you didn't, but actually on the CC view, it's there. And this is what I call, we're all as radiologists familiar with that YouTube video of people throwing basketballs around, and you need to count the basketballs, and then a gorilla is going through the audience and nobody looks at it. This is what I call instant happiness, satisfaction of search. I believe in German, aha-Erlebnis, as I'm sometimes being called by my former professor. So it's very human nature that you find something, you think, I detected, recall, next one. And then with this information, your eye is being drawn to another area, and then you actually see, well, to be honest, there is an irregular mass with a small calcification inside. So she was recalled for a cyst, but in the end, we detected an invasive cancer in some other part of the breast. So again, these are all everyday cases. It doesn't occur every day. Sometimes we have contrast-enhanced mammography images and we say, well, okay, this didn't really help us that much. But in the end, you need to create a work path. You cannot decide on an individual base, contrast yes or no, but you should have indications. That's why we work with indications. And sometimes for MRI or PET-CT, you have an indication, but in hindsight, you think, well, okay, it didn't really get me there that much. And that's something you have to accept because we work in indications and not on individual basis. Now, I think this is only the second to last one. This was a recall from this asymmetry on the left breast, only seen in the CC view. So I'll give you the abnormality. And this is what we observed on the SAMs after we did the recall. So this is already the clinical follow-up. And since it's a little bit less interesting case, you already see that the asymmetry is gone. So every image is a little bit slightly different projection. So you already see that the asymmetry is resolving, it's going away. And you also see no enhancement there at all. So you have a mammographic substrate that is going away and you don't have any enhancement there. So this was deemed to be a negative case with a high negative predictive value. We don't do any ultrasound, we don't do any follow-up, we don't do any breast MRI or tomo or anything. This is just immediate reinsurance and back to the screening after 2 to 2.5 years in the Netherlands. Let's see. I'll continue to case 12. I believe this is the last one. 48-year-old female, a little bit more interactive. This is the mammogram. And she had she had a palpable mass in the right breast. I forgot to tell you.
Mm-hmm.
People are very fond of the Birat 4 classification, I noticed.
I should have added the ABC as we did
Yeah,
previous.
It's not allowed in contrast-enhanced mammography.
I know. You already mentioned. I remember well. There's a lot of discussion in the background about the use of additional spots in cases like the previous one. What's your approach to spot compressions and stuff?
I love it. I love it more than tomosynthesis, to be honest.
Pascal, did you hear that?
I was trained old school, and if you have very dedicated technicians, a little bit old school technicians, and you say, I want a spot compression there, they said, easy, let's go. And they sort of think of it as a challenge to get it spot on.
Very much agree with that.
It's very satisfactory if you have spot on spot compression and then it's completely gone, because in a lot of times you see the same projection occurring with tomosynthesis and you slide through it and you say, well, I don't think there's something going on there. But I still have a little bit of that uneasy feeling, to be honest. And I was just trained by Carla Boetes with turning, rolling, extending, pressing, and everything. And she always said, if you have a mammographic issue, first solve it mammographically. Do not go to ultrasound and then go back to the mammogram. No, first get rid of that lesion and prove it on your mammogram that it's not there. And that worked fine. But again, I know that a lot of newer generation radiologists are being trained with tomosynthesis, but I know that there are also studies that there's not really a benefit between tomosynthesis as problem solver or the old school compression, rolling, turning, and everything. So I think it's what you prefer. Here it's a BIRADS 4, which I can imagine because there's an obscured mass in the right breast, which indeed was the palpable mass. She had a cyst over there, but we also saw an architectural distortion in the central part of the left breast. I tried to go back. Just give me a second. I'll just continue here. It doesn't allow me to go back for some reason sometimes, but there was an architectural distortion. I will show you tomosynthesis in a minute to actually show it a little bit better. But seeing you have an architectural distortion in the left breast, again, I will show you tomosynthesis and better images later. What would you do? So we have a cyst on the side that she was symptomatic. That's very clear. But now we have this vague architectural distortion in the left breast. What are we going to do? What would
Right,
you?
it's my that's my task, and this is where we go.
And maybe in between we can do some Q&A to catch up a little bit on time if you like. So indeed, I agree with B to some extent. We already did that because we had a little bit the idea, but is this something real? Are we being tricked or fooled, or is this a real architectural distortion? And it turned out to be a real architecture. So I can imagine that some people go for B and do a digital breast tomosynthesis. I will show you the images. But then again, you show that it's a real architectural distortion. And we see the number of people doing SEM already increasing, which is a good sign, I think. So at least I'm not doing this for naught, so to say. And this was the architectural distortion. So in two views, it was actually there. And we did a contrast enhanced mammography in this case. I will skip this one, Matthias, just to have some room for Q&A as well. So I think the most important is this. So at the site of the architectural distortion, we also have some non-mass enhancement there, which makes it a little bit more tricky. It's an architectural distortion with enhancement, low conspicuity, non-mass enhancement. So this cries invasive lobular carcinoma all over. Not knowing whether that's truly the case, but at least we need to figure it out. We did an ultrasound, but we couldn't really find it. On tomosynthesis, yes, you had the impression that the architectural distortion was real, but we had difficulty in really targeting the depth of the lesion because it was a little bit strangely formed in morphology. And now, since 1.5 years, we also have the opportunity to do contrast-enhanced stereotactic biopsy. So we thought, well, the best way we see it is with enhancement. So we tried to target the enhancement. So in this case, we decided to go for contrast-enhanced stereotactic biopsy. And this is how these images look. I know it's a rather new development in contrast-enhanced mammography, a very good development because that was always a little bit of a drawback of contrast-enhanced mammography. But in general, you can recognize these images that we're used to with doing stereotactic biopsy of calcifications. And I also want to emphasize that this is not really important. This is see one, do one, teach one, to be honest. It's really no difficulty, no change whether you target enhancement or you target calcifications. It's absolutely the same. So don't be ever afraid when you're going to introduce it. See one, do one, teach one. It's that easy. So here in the targeting window, you have the non-mass enhancement again. It's very subtle, so it's a little bit better to be appreciated on diagnostic views. You can sort of determine the X and Y coordinates, and then with angled views, so a little bit the way we used to do it before we had tomosynthesis guided biopsies, we make two 15 degrees angle views to assess the depth of the lesion. Then again, you apply a local anesthetic, you insert the vacuum assisted needle, you do a pre-fire checkup, and then you position the needle at the correct place. You take the biopsy samples, and in the end, you leave a marker there. You get a small hematoma, of course, which is enhancing also a little bit. It appears like it's enhancing, but it's just blood products over there. And you can actually quite nicely do that. Our experience, without looking at the catheter placement, so just the procedure with the images in itself, 50 minutes of time. Pain score that we are keeping up at this point from a 1 to 10 score, with 10 being the most extreme pain. We have a median of 3. So it's not nice, but it's doable and not that different from stereotactic biopsy. We had one collapse because the patient fainted, but those are all things that we are used to with encountering when doing stereotactic biopsy. So again, in general, this is just a stereotactic biopsy with contrast. I cannot put it any other way, but I wanted to show you the images as well, because to some people it's rather new. It seems to be some kind of mystified new procedure, but it's actually not, and this is the way the images would look like. In the end, yes, it was an invasive lobular carcinoma. So very easy to do and very useful in everyday clinical practice. And with that, I would like to thank you all for your very enthusiastic participation. I hope I gave you a plethora of interesting cases. And well, there's some time, I think, for some Q&A, Matthias.
Absolutely, that was the plan, but the plan was obviously also to thank you for this awesome presentation. To quote only one feedback which I received, I'm thrilled with this education. It's phenomenal. So I can also agree more, because you kind of combined real hands-on teaching with real life clinical experience, plus included first-hand experience in latest technology, plus also latest articles you published talk about the RACER trial, for instance. And thanks once again. This was really amazing. But let's just jump in right in the discussion, because obviously within 1 hour of case reading, we cannot solve and answer all the questions which obviously are there in the audience. Let's start with a quick warm-up question. What's your approach to SEM in case of patients with implants? No problem, or any specific stuff you should have in mind?
Do MRI.
Yeah. Okay.
Yeah, you get a lot of distortions by the you can do contrast enhanced mammography with implants, but you get a sort of a distorted area surrounding the implants, and when they're taking up a lot of space within the breast, you only get a very small part of the breast that you can diagnostically appreciate with SEM. And again, there's no reason to do not do breast MRI. I think having implants is an actual very good indication to do a breast MRI instead of a contrast enhanced mammography. On the other hand, if you have a cardiac pacemaker or anything, it's a very good idea to do a contrast enhanced mammography and not an MRI. So
That's clear.
It's not forbidden to do MRI.
Okay, so in a nutshell, this is a problem maker, and this is one of the cases where you would go for MR, which is, again, not a competitor, but it's a teammate. Fantastic. Do you perform in certain cases by intention delayed imaging? Because when we discussed parenchyma enhancement, you talked about the curves and the blue maps, etc. So is there any use of delayed imaging in SEM? Because we all know there are some working groups who do this and publish this. And
yeah, I think that also relates a little bit to the quantification of gray values and everything, because I see sometimes papers with people measuring gray values and everything. That's very tricky, I think, because you need to remember that will probably work on your system in your hospital with your protocol. I would like to see multi-vendor, multi-center studies doing this, because the reason behind it is we sometimes use different iodine contrast dose. We sometimes have a different machine, so maybe one of us has a logic, other one has a GE. And although the images appear roughly the same, the algorithm is different in some cases. So it's very tricky to measure a gray value from, for example, a GE system and then compare it to a gray value on a hologic system. So I think that's very tricky. If you're going to do these kinds of things, you need to stay to the same machine and the same brand. Then I think it's best to compare it. But if you have variation like breast thickness or anything, I think it becomes tricky. Also, I don't really believe that there's that much information in contrast enhanced mammography as we're used to looking at Christiana Kuhl's signal intensity time curves, because that's a whole different contrast. We have only a very small volume of contrast. We have this time to enhancement curves, which are very rapid assessment. And you should remember that the peak enhancement with breast MRI, where we do these initial results, is already at 90 to 100 seconds. And that's the time point when I finished administrating my iodinated contrast. So it's a whole different recipe that you're using. And I don't think it's very good to assess that on a very basic level like we do in MRI. There seems to be some information there, but it's very difficult to get your finger behind it in terms of measuring it or anything. So there I would be very interested to look if AI could help us in some way to maybe not quantify it in numbers, but maybe like high risk, low risk, or anything like this.
Okay, that's a clear answer. Pascal, do you have any questions?
Oh yes, oh yes. If you follow up, I mean, I think we discussed last time, Mark, with the late images. So I think it was a quite clear point. One thing I think we also shortly discussed the last time is, do you have any update on what is the optimal like injection dose, like iodine concentration, volume, and also injection rate of contrast? Can you say, because that's one of the open things, some people do this and some people do that. So what's your experience regarding that? Is anything you can recommend, or is it anyway not that important?
No, I am not aware of any studies on that. I know there's a lot of debate on that, on how we can optimize the protocol. And I truly believe that there's room for improvement, because I talked to Serge Muller from GE. He's one of the sort of godfathers of the development of their commercial system. And I said, where is this protocol coming from? And he actually admitted that this was sort of based on phantom measurements and preclinical examinations based on CT protocols, but based on CT protocols at the turn of the millennium. So these are not comparable with the CT protocols that we have nowadays with much lower concentrations and everything. That's much more developed in the meantime than contrast enhanced mammography. Contrast mammography is sort of making a stagnation there and said, well, this works. But it's very difficult to perform studies in a way to look at different contrast administration strategies. So yes, I think there's a complete area to still be discovered there. We have iodine shortages everywhere. We want to take consideration of the environment. So yes, I think there's room for improvement there. Absolutely.
Yeah, I mean, I think it's quite interesting. Also, the contrast dynamics, I think they're incompletely understood. Like, we inject without compression, then we do images with compression, we release the compression, do another image, compress again. So it's quite interesting that research currently rather focuses on the pure diagnostic aspect. I mean, I think it's of course the most important, but I would also be very happy if some more like systematic research there would be done, even though I absolutely admit you need large numbers and probably big differences between contrast, and probably the difference is not that big. Yeah.
It's absolutely true what you say. There's much to be learned from there. It looks like contrast enhanced mammography is a sort of a fixed modality and it's already done. No, absolutely not. We're currently working on QC protocols to define together with some clinical clinicians the sort of degree of level that a mammography system should reach to be recognized as a contrast enhanced mammography system, because there's no consensus there as well. We know from some vendors that they perform at the same level, but if there's a new vendor, I think we should have lower thresholds of definition that this is the level that you should at least acquire to be recognized as a good contrast enhanced mammography system, like we do in the image quality of mammography as well. So have some sort of consensus there, and then we can still further explore, like you said, the different strategies. Maybe there's a difference for CT. We have different protocols, cardiac, lung, you name it. And maybe we could use a different protocol for neoadjuvant chemo response monitoring, because we have one affected site, so to say. And right now with response monitoring, we always do both sides, which makes absolutely no sense. So why do something dynamic during response monitoring of only the known cancer? Because we know from studies that during chemotherapy, you're not going to develop a contralateral breast cancer. That's extremely rare. So why not focus with more advanced SEM techniques on response monitoring and see whether we can win something there as well?
One thing, because it's actually a follow-up on the other part. A common finding, I mean, also in the lexicon, is the enhancing asymmetry. Isn't it? Because I'm looking at some of those enhancing asymmetries of our own cases, and sometimes there seems to be a potential washout. So what do you think about enhancing asymmetries? Is it really some probable sort of washout happening between images, or do you really think there is something? Has it something to do with the acquisition? Because one of our attendees asked it, and it's a question I have discussed also several times. So I would be very interested. What's your opinion? What's an enhancing asymmetry? Is it a common finding for you? Is it a generally suspicious finding? Just your thoughts on that.
I with asymmetries that are enhancement, I would also be very cautious, because it can be a sign of an invasive lobular carcinoma, as we've seen here in these cases. I would always look to see if there's something that sort of reveals that something is happening there. Like the case that I showed you, you actually see something occurring there now that you know it. I would look for evolving architectural distortions, or maybe some subtle calcifications that pop up. If you have maybe one or two calcifications suddenly appearing there, then it immediately becomes a red flag for me. But there are also enhancing asymmetries that we biopsy, and it turns out to be adenosis or hyperplasia or anything. And I think with the better availability of contrast-enhanced stereotactic biopsy and the ease that you can perform these kinds of images, our knowledge about these entities will grow rapidly, because I'm not sure what to think of it at this point, other than to be on the safe side and biopsy it. But I think with increasing knowledge via the route of contrast-enhanced biopsy, we can learn a lot more from that and then get a feel for what can be neglected and what not. At this point, with doing more than 1,000 cases each year, we actually have well-defined masses that are enhancing a little bit, that we're already confident enough to say, well, these are fibroadenomas. Always be a little bit on the cautious side, but sometimes you biopsy and say, well, I think this is a fibroadenoma, and it turns out to be a fibroadenoma. So you increase your level of experience much more with just exposing yourself to these kinds of images, getting the feedback from pathology. And then I still remember with breast MRI, with my first residency with Carla, I targeted many of these, what we then called UBOs, unidentified bright objects, and I had complete lineups of patients of targeting ultrasounds all over. And I think we all recognized during the decade, we sort of say, well, all these foci, we're confident with not doing anything with them anymore. And that's just growing experience, I think. And I think the same will be expected with these kinds of abnormalities.
Great. What's one thing you'd also just mentioned, because I'm very much interested in it, that is microcalcifications. There was one of our attendees who asked, like, provocantly, well, yes, you said, rightly so, you may miss DCS, which is not enhancing, so you would rather go for biopsy. And our attendee said, wouldn't that be called overdiagnosis? So what's your take on, if there is no enhancement, do you think it's oncologically safe to probably do like a 1-year follow-up, which actually we do quite a lot, because we were interested very much in the topic doing MRI and calcifications. Of course, we switched quickly to at least additional in comparison to contrast-enhanced mammography. Yes, it's probably not as good as, but still, we very often, particularly if you have several clusters of calcifications, you can't do a biopsy in all of them. We very regularly do a follow-up in case contrast-enhanced mammography is negative. What do you think about that? Is it like very risky, or what would you say?
I think very exciting to study that, because that's always the topic of overdiagnosis or overdetection, as I would like to call it. It's always a food for a lot of debate. Are we detecting too much, or are we treating too much? Personally, I would like to know every kind of cancer cell within my body, but only if I also know which one is going to kill me. And that's, I think, the gap that we still have. We can detect a lot of cancers within our body, but we're not sure which one are going to kill us in the end. And that's, I think, the gap that we have. And this is especially true with DCAS, which we know, well, we think it's going to be a cancer at some point in our life. So right now we're going to treat it as a cancer. but it would be very nice to have some kind of risk profiling or modeling or anything that you can say, okay, we can sort of consider them maybe as BRCA gene mutation carriers. So you have a very high risk, and maybe instead of doing surgery at a certain age, you can say, well, you're going to increase your follow-up with contrast enhanced mammography each year until until there is some mass forming or until there is enhancement. But this is really something exciting, I think. Maybe the future for contrast enhanced mammography or any kind of application, also breast MRI in that aspect, to see whether we can go from treating DCIS surgically to defining these women as very high risk patients, like you have BRCA gene mutation carriers. And whichever you're going to use, MRI or SEM, I think that this is very interesting stuff to study, and a further need for de-escalation, because I think de-escalation on a safe way is always very important. So that's my general opinion on that, but it's too early to really implement that clinically. It's a very big risk that you take, so you should do very robust studies on that as well.
Excellent. Thank you very much, Mark. Matthias, what do you think? Wrap up, or one last question? I have one, but if you say, Pascal, we need to stop it, because I could talk with Mark for hours.
Well, it's not only you. I have a list for until midnight, at least Berlin time. But this is one of the sad moments being the host of these sessions. You have to wrap up because you have to at least try to stick to your timeline. I think let's postpone this to the next one, huh, Mark? What do you think?
Yeah, sure. Just keep the list, and maybe we should do only a Q&A for once.
A Q&A session would be great, yeah.
Yeah, but I really, it's no exaggeration. I have a massive list of questions, which are all great, honestly. It was not the aim, so hopefully we didn't promise something. It was not the aim of the session to answer all questions. It was just the aim to give you a careful expert insights into SEM, answer many questions, but not just to go through like a textbook to all aspects. But there are questions about DCS, BPE, specifics of protocols, clinical aspects. So maybe we think about setting up a sequel to this. We will be happy to host it for Mark anytime. But at the time being, let's wrap it up, because you have expected 90 minutes. Many of you will have a holiday tomorrow, so let's not postpone the well-deserved evening. The feedback poll is already running. It's super important for us, not for fishing for compliment, not at all. That's not the School of Radiology style. It's for us to learn from you what you think is more important, what you liked, obviously also, but also what you think would be interesting for a sequel or for another format. So please take the final minutes to give us this feedback. And I sincerely want to thank you all, guys. We had more than 550 registrations, just double-checked it. Many of you will go to the video later on to review it. This is really a massive response. I really like this. I'm really happy to host these sessions for stellar speakers like Mark to share the super important and great knowledge of him. But first of all, obviously, Mark, we have to thank you once again. Final time, but still stressed. This was a fantastic session. I really liked it. It's always cool to have these nasty, difficult breasts, and then all of a sudden there comes blop, the SEM moment where we find a solution. This is always cool, but this was not only the only case. Obviously, you had very, very difficult mamma horribilis, as we call it in German. So we have obviously microcalcification, but you really need some help, like in this one with the pleomorphic linear branching type of calcifications on the rest side. And all of a sudden, you see more, obviously, non-mass, which is certainly going beyond the calcification. So really great cases, loved it. I also loved, and I'm sure you all guys did it as well, that you highlighted the biopsy, but that you also demystified it, because this is also my impression. I do not have any hands-on experience on that, unfortunately, hopefully soon. But there's a lot of mythology going around, like the Holy Grail, and only a few have it, and etc. You nail it. And said to us, this is how it goes. Really liked also the clinical examples, fantastic. But this was not just a case reading session with great cases by an expert. It was all evidence-based. Only the RACER trial itself speaks that this is an expert also in the academic field. We will put the link to the RACER trial, which is open access, also in the email afterwards, so you can study also the latest data from Mark and his group. But the quotation, what I really loved most, which is super honest, is SAM is an adjunct to mammography, not a replacement. I really love the sentence. This doesn't mean that SAM is not great, but it's an adjunct. Nothing more and nothing less. Fantastic statement. This was my favorite screenshot. I hope it was okay to screenshot it, Mark. And now I switch the role, not the moderator. I will just give you some final words. What's up next? If you filled out the feedback poll, or if you send up email to our office, you will obviously get a certificate personally signed by us, +2 CME credits. I'm super happy that Mark agreed to share the video of this lecture only for the attendees, obviously, who registered, and this will be shared after we finalized video editing. Give us like a week or so to do this. Is quite some work. There is literature abundance, and one of which is this special issue where also Mark contributed fantastic articles on SAM. Follow the QR code. It's also linked on the website, and you may want, if you liked our way of teaching and sharing essential and expert knowledge in breast MR, come back to our platform. This is not a promotion, but you may want to know that Laszlo Tabar will be back in May, not May the 4th, but May the 14th this year. For the 6th time, he will speak about also difficult topic, dense breast imaging. So basically a sequel on the other side of today's session. And on June 2nd, there will be our famous Foundations of Breast Imaging case reading session. All these sessions are free. So that's the final slide from my side. Before I step again and for the final time in the background, follow us. Stay tuned with the School of Radiology. And as it's our good tradition, Pascal, now it's your time. 1, 2, 3 for the final words.
Thank you, Matthias. Dear colleagues, it was great having you. Mark, it was fantastic having you again. And I'm very much looking forward to having you again, actually. And with this, I don't have many words. I have the island. I'm retreating there. And I wish you all a wonderful evening or whatever time is in your time zone. And Mark, thanks again. That was really, as always, fantastic.
Yeah. Absolutely. Thank you all very much. Have a fantastic holiday tomorrow if you're lucky and have a 1st of May holiday. Otherwise, have a great weekend and see you soon, either on our platform at USOBI or wherever you are. Goodbye.